Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Renslow Sherer discusses a case scenario of managing virologic failure in a person living with HIV who is heavily treatment experienced. Dr. Sherer is the director of the International HIV Training Center and a professor of medicine at the University of Chicago. For more information about Dr. Sherer and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now let's get started and hear what Dr. Sherer has to say.
Managing virologic failure with heavy treatment experience. So here's our patient. This is the background of a 52-year-old woman who's diagnosed with HIV in 1995 when she was tested for a pregnancy. She has had episodes of depression, of substance use, and housing insecurity with episodes of viremia between 1995 and 2012. Has been on many different therapies, combination nuke therapies in the early days, followed by nukes with the anchor drugs of indinavir, nelfinavir, the earliest PIs, nevirapine, the early NNRTI, and efavirenz. From 2013 to 2015 was then transitioned to boosted darunavir with the integrase inhibitor raltegravir and maraviroc with variable adherence. And in 2015, a genotype showed pan-genotypic resistance to the nukes, to the NNRTIs, to the PIs. The N155H was present for the integrase inhibitors, and her virus was dual mixed tropic, meaning that maraviroc was no longer effective. And at the time, she was switched to boosted darunavir, ritonavir twice daily with FTC, TAF, and dolutegravir twice daily, again with intermittent suppression, but also poor adherence. And her current CD4 cell count is 390, and her virus load is between 1,000 and 2,500 with recurrence of substance use and, again, variable adherence. And we have a resistance test that's pending. So I just want to say editorially, I think these are the good news of the modern era for HIV management is we don't see as many patients like this as we used to. And we've seen that's fallen from anywhere as high as 25 to 30% of practices down to less than 5% of patients in most practices. So it's fortunately for our patients and for us a much less common occurrence, but we certainly still see it. And it's a tremendous clinical challenge. And they divide roughly into two different target populations, one like our patient, who through no fault of her own or for the clinicians who managed her in the early days, was just subjected to less potent regimens, had more opportunity to develop resistance mutations. Many of those less potent regimens had low resistance barriers, particularly those that were insufficiently potent, like double nucleoside regimens. And then there's a younger population who fits in this group, some of whom have had congenital HIV, who are now adults, who were initially treated with less potent regimens that had low resistance barriers. So thinking about this just schematically and looking at sort of the history of antiretroviral therapy, you can see that we have many highly adherent patients who were aggressively treated in the early days with non-fully suppressive regimens. And that led to multidrug resistance. So, we started with zidovudine monotherapy, and then we had dual nucleosides and sequential monotherapy. And only, around 1995, 1996, did we realize that either pairing a 3-drug regimen with a boosted PI or with the NNRTI nevirapine and later efavirenz was that effective. And that's sort of at the time that we learned about hitting hard and hitting early. And there was experimentation also in the early 2000s because of concern for drug toxicity with discontinuations, and that also led to some disruption of therapy and suboptimal therapy. So we really are in a modern era that is substantially better. So if we return to our patient and look again at the Stanford database interpretation, you can see this is bad news, bad news, bad news everywhere. So high-level resistance across the board. So if you just look at those details, you can see it's because there's the 41 and the 210 and the 215 M184V, and even the 69 insertion. So this is high-level nuke resistance of the highest order. Among the PIs, you know that the first thing you do is count the resistance mutations, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 resistance mutations with all the principal locations, 10 and 90 and 82 present, signifying high-level resistance. I do see that darunavir manages to get by at an intermediate level, might be a contributor. If you have to pick one of the members of that class, that would be the first choice. NNRTIs are no good. You count resistance mutations for the second generation, and you can see that there's just pan resistance across the class, and then high-level resistance for the integrase class. So we really have very few options, and also this patient's dual mixed tropic. So with our first-line therapies and second-line therapies, really very few options for this patient. All right, so what are our options for second line and beyond? So they base this in the DHHS guidelines on susceptibility or lack of susceptibility to boosted PIs and dolutegravir. Well, in this case, they're susceptible to neither, which means we're going to do our best to cobble together a regimen with 2 or 3 fully active drugs, and that's going to get us into this new territory. So in the existing classes, what drugs may have residual activity? Boosted PI. And the PI of choice in that setting is boosted darunavir. And you saw that there was some room for the use of darunavir in our patient population. So that would be the dosing formulation of choice here would be darunavir 600 milligrams twice daily if there are any darunavir mutations. And then you can consider the nukes. We already saw from Nadia that even in the presence of a K65R and the M184V, we were able to recycle successfully tenofovir and 3TC. And then we're in the business of drugs with a novel mechanism of action that have no known cross-resistance currently. So infirmotide, fostemsavir, ibalizumab, IV every 2 weeks, and lenacapavir subcutaneously every 6 months. So already you can see dosing is complicated and you have to prepare your patient for participation in a fairly complicated regimen. So let's just think about some of the data that has led to the availability of these drugs, the phase 3 registrational trials. This is TMB-301, 311, looking at, and you'll see that these studies are structured pretty much in the same way, where you take the current regimen that a patient's receiving, use the study drug for 7 to 14 days, so you can see the effect of the study drug alone. And then there's a period where patients are allowed to receive an optimized background, OBR, that is cobbling together the best possible regimen for an individual patient based on their genotype and phenotype. And so you can see here the entry criteria were people with virus loads over 1,000, who had been on treatment for 6 months or more, who were known to be resistant to one or more members of all 3 classes, and to be sensitive to at least one drug in the optimized background. That was 40 individuals in this particular study. And so they got 2,000 milligrams IV for 7 days, and they continued whatever was failing in their antiretroviral therapy regimen for 14 days. Then they were switched to ibalizumab, 800 milligrams IV every 2 weeks, and that's their maintenance dose, and switched to the optimized background. And remarkably, in this study, those who achieved a greater than half-log virus load decline was 83% of people by day 14. And those who achieved virus loads less than 50, you can see by week 25 was 43%, and 56% by week 48 and 96. So ibalizumab alone was able to lead to long-term virologic control in half the patients in this selected group. And that's, I think those are impressive results. We see that ibalizumab used in this fashion with a loading dose, 2 grams IV on day 7, then receiving 800 milligrams IV 14 days later and every 14 days can have long-term suppression. So let's turn then to fostemsavir and the registrational trial that was used in patients with multidrug resistance. And there were actually 2 different cohorts here that were enrolled in this clinical trial. So this was folks who were randomized, had 1 or 2 known remaining options for antiretroviral therapy. So they had greater or equal to one fully active approved agent or class, but no other regimen could be easily constructed with the remaining agent. So they were resistant to almost everything. That was 272 people. And then they allowed for compassionate use that folks who had virtually zero options, and there were 99 people in that group, to receive fostemsavir with whatever optimized background could be cobbled together. And the primary endpoint was in this study was the mean change in virus load. You can see that by day 9 to day 96, people were given fostemsavir 600 milligrams twice a day and an optimized background. And the results were, in the randomized cohort, those achieving a virus load less than 40 was 60% total. And those who had some level of viremia was 30%. So about 60% could be controlled. And even in the non-randomized group, where there were no active drugs in the background, about a third of people were completely controlled. And it's noted that there was a difference overall in those randomized patients who had a baseline CD4 cell less than 20. 2/3 of them had their CD4 cell count go above 200 by week 240. So a clear demonstration of benefit in terms of the CD4 cell response with the use of fostemsavir as well. So there's some practical considerations in the use of these drugs. I've already mentioned on the left that ibalizumab is administered IV every 2 weeks. You have to have an initial infusion over about a 30-minute period with an hour-long period of observation. Maintenance doses also require observation for about 15 minutes, and the infusion can be greater than equal to 15 minutes, or you can give it an undiluted IV push over about 30 seconds. So it takes a little bit of time to administer ibalizumab, and we do see the most common adverse events are some dizziness, nausea, diarrhea, and rash with the use of ibalizumab. In terms of fostemsavir, this is an oral extended release tablet that's taken twice daily with or without food. It can't be crushed or chewed. It has to be swallowed whole. And the adverse events are pretty well tolerated. Around 5% of people have some nausea. And then the third drug that's so important, I think, in this new toolbox that we have for heavily treatment experience is the latest and newest class of drugs, the capsid inhibitor lenacapavir. And its first use was in the CAPELLA trial in heavily treatment experienced patients. And here you'll see the very same formulation as the clinical trials that I've already shown you. So the patient population is people who had virus loads over 400 who were known to be resistant to 2 or more drugs, to have less than 2 fully active drugs out of the 4 main treatment classes. And they were viremic at screening. And this here again, just like in the BRIGHTE trial that I just mentioned with fostemsavir, there's a randomized cohort, and then there were a group of people who had virtually nothing else that they could take. That was 36 people, and they were allowed to enter the study as well. In the randomized cohort, people were given functional monotherapy. Well, actually, in all 3 cohorts, functional monotherapy for a period of 14 days with oral lenacapavir and a failing regimen, or compared to a placebo and a failing regimen. And then for maintenance therapy, the group that had received oral lenacapavir then received subcutaneous injections every 6 months for 52 weeks with an optimized background. And the group that had been given placebo then transitioned to the oral lenacapavir for 14 days, and then subcutaneous lenacapavir every 6 months. And you can see that in the non-randomized group, they immediately got oral lenacapavir and then transitioned to subcutaneous lenacapavir. So with that background, these are the results. Quite impressive that among those in the randomized cohort, now remember, you could use investigational drugs in these trials. So in the BRIGHTE study, some of those people on investigational drugs used ibalizumab. In this study, some of the people who were treated in the randomized cohort also had fostemsavir and ibalizumab in their background. A stunning achievement of 83 and 86% of people achieving virus load suppression, less than 50 copies and less than 200 copies, respectively. There were instances of virologic failure, as you can see, 14% at the less than 50 threshold in the randomized cohort. Equally impressive in the combined non-randomized and randomized cohort is 78 and 82% success overall. as well as the demonstration of a CD4 cell increase of 83 cells at week 52 in this heavily treatment-experienced patient population. These are really gratifying results and show us that we do have effective new tools for our heavily treatment-experienced patients. Now, it's also very important what we've learned about the use of lenacapavir, because this is the most vulnerable kind of treatment regimen for a new drug. And inevitably, as expected, we began to see resistance mutations occurring with lenacapavir. It occurred in 9 out of 72 patients. 4 of them had no active drugs in the optimized background. 5 had inadequate adherence to the optimized background. So it appears that there were potentially some reasons for the development of this resistance. So there was lack of support. And you can see the type of lenacapavir resistance and the sites of those resistance mutations at the 67 locus, 70, 74, 1055, and 107. And pretty evenly distributed across the 2 different cohorts. The most common mutations were on the top line, the M66I, Q67H invariants, and the K70H invariant. There was only 1 patient throughout the whole study who stopped because of an injection site reaction, ISR, a nodule that was deemed to be grade 1. And you can see that there were substantial numbers of injection site reactions, a little swelling, a little erythema. So a little bit more about how it's dosed, how lenacapavir is administered. So after the oral phase, it's administered subcutaneously every 26 weeks. And the window period for successful therapy is plus or minus 2 weeks. And the initial dosing option is either to give 927 milligrams sub-Q and 600 milligrams orally on day 1 and 600 milligrams orally on day 2, or you can give the 600 milligram oral option day 1 or 2, and then come back 300 milligrams orally on day 8 and begin subcutaneous administration on day 15. As it stands now, the dosage is only administered by a healthcare professional in the abdomen, and it's given as 2 injections, so each one is 463.5 milligrams per 1.5 mLs. The most common adverse events with an incidence over 3% are either nausea or the kind of injection site reactions that are relatively minor and well tolerated. So as you saw, there was only 1 patient who discontinued because of these injections. All right, so if we go back to our case and think about this patient, clearly the DHHS guidelines say that the goal in patients with resistance to second-generation integrase inhibitors, as our patient had, and to a boosted PI, we want to have 3 fully active drugs. So what our options are in this case is infirmicide, fostemsavir, ibalizumab, and lenacapavir. And also the suggestion that, remember, we had partial resistance to boosted darunavir and the question of the recycling of the nukes. So what could be done in this patient is to use fostemsavir and lenacapavir as one example with FTC, 3TC, and boosted darunavir. That would be a reasonable regimen. But I think for sure, you're going to want to use one member, and ideally 2 members of this class in the next regimen that you have. So at least 2 fully active, and if possible, 3 fully active drugs.
Thank you very much to Dr. Sherer, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2023 program on the Clinical Care Options website, and to access the slide set for managing ART in challenging scenarios, click on the links in the show notes for this episode. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.